So, to everyone here joining, thank you all so much. If you're watching this online, recorded, thank you for coming to the website to watch this. We've got a really interesting evening ahead of us with two amazing papers to hear about. So first of all, we've got Chloe and Dunja. So they're both from Durham, and they're going to be talking about their paper and reviewing the room. And it's important to say, I think that Chloe, it's about a year now since you submitted your PhD, if I get this correctly. So congratulations on your 1-year defence. That's an amazing achievement. And so we'll hear from Chloe and Dunja first, and we'll have questions for them. And then afterwards, in the second half, we're going to be hearing from Sarah. Sarah's from King's College London, and we'll be hearing a bit more about her paper. For the case of Zoom policy, if you can, please keep your microphones off during the talk to allow for Chloe and Dunja to speak. At the end, with regards to questions, you're very welcome to put them on the Zoom chat or to speak up. But without further ado, I think it'd be really interesting to hear more about this paper. So Chloe and Dunja, the floor is yours.
Okay, so the paper we're presenting today is now a published paper, but at the time we submitted it for as an abstract for the IME conference, it was still just an abstract, just a work in progress. So the paper reviewing the womb is very much, while I'm now at Durham and Danya's at Lancaster, it's very much a product of our time at Manchester, and we both did our PhDs there together, and it was very much a journey instrumentalised in sort of really brought about by the two other amazing women that we wrote this paper with. So their names are on there as well, even though they can't be with us today. Can you change the slide, Danya?
Yeah.
Thanks. So it's just a bit of background to where the paper came from. Initially, we got a grant from the Institute of Medical Ethics to host a one-day symposium called Reconceiving the Womb in Medicine, Law and Society. And the reason we sought out that funding and hosted that event was to showcase lots of the work that was going on within the Manchester Law School at the time. So we had lots of people who were working on historical perspectives on the womb from disciplines like history and sociology. And we had us doing our law and ethics stuff on the womb. Some of us looking at things that are a bit more sci-fi, and some people looking at contemporary womb technologies. And we kind of wanted to bring that together along with people outside of our centre to sort of build a multidisciplinary collaborative network of womb researchers to think a bit more about where the links in our work were. And we ended up really focusing on this theme of tracing attitudes to the womb over time. So essentially what the purpose of the paper was to do then was to trace out these discussions on attitudes to female reproduction that in the end we felt were shaped by historical misunderstandings of procreation, and specifically the female body and the womb itself, and how those misunderstandings have perpetuated an approach to female bodies and obstetric care and potentially future technologies that continues to and will continue to subjugate and other women who gestate and bear children until we challenge those narratives.
Okay. Thanks, Chloe, for this really lovely introduction to the paper. So just to briefly go back to the other two authors that you probably might know, you might be familiar with their names as well, but they're also Manchester-based. So Alex Mollock is a senior lecturer in medical law at CSEP, which is short for Center for Social Ethics and Policy. And Margot Brazier is an emerita professor also at Manchester. And I guess this paper was really a joint effort in every sense of the word. So it's very difficult to try and describe who actually did which part, although the introduction of the paper, which I'll say something about in a second, was more of a historical bit that was done by Margot, who, even though she is quite a famous medical law researcher, also has been doing some historical research in recent times. So that also formed the beginning of our paper, as Chloe said, kind of firstly historical tracing of understandings of the womb. So this is just on this slide, you can just see a short overview of the paper. So basically we were interested in reviewing the womb in the sense of reviewing the perceptions of the womb. And in particular, we identified as one of the key themes, this idea of the womb as a site of conflict. So maternal fetal conflict, more narrowly speaking, but I guess also we could say social conflict in terms of women being controlled or attempts to control women's gestating bodies. And then after looking at first historical introduction to this, we then looked at the more contemporary context of this, especially as impacted by the development of technologies such as prenatal screening and treatment. And finally, we looked at more futuristic technologies, such as the potential for full ectogestation to develop, which is a topic that Chloe is the expert on, so she will say more about it in a later part of the presentation. But our overall argument was that this conflict perception is very much both conceptually and empirically speaking inaccurate, and moreover that it is a dangerous perception to have, even though it's one that is very deeply entrenched in society. So looking at the history of how the womb has been perceived, the contemporary state of reproductive technologies and attitudes around pregnancy and childbearing, and finally the potential futures that might come with new technologies, we believe that reframing this conception and kind of emphatically moving away from this conflict perception is necessary in order for the autonomy of those who gestate to be maintained. So the first part of our paper, entitled Hidden from View, is the historical bit that I just mentioned. And it's a really fascinating and detailed overview of views about women's bodies, about uteruses, and about gestation present from the Middle Ages up to more recently. It looks at not only, for example, philosophers' views, but also at kind of medical and midwifery textbooks that were used at the time. So it really presents a really fascinating overview of opinions that were held both, you know, within the general public and by so-called experts. And one of the main themes arising from this historical overview is that wombs were seen as something to be suspicious about, partly due to the fact that they were inaccessible to men, both in terms of being, you know, something that could not be interacted with and seen into the way it can be today with the development of technology, but also in the sense that these are typically experiences that are had. Experiences related to gestation and childbirth typically are something that's had by women, and so to men who were the dominant knowledge producers and creators, this was fully inaccessible knowledge, and this led to a lot of perceptions of the womb as something mysterious, as something possibly wicked, you know, as something with a great power, but also potentially also quite dangerous. And this kind of mysterious view of the womb led to also ideas about how the womb needs to be controlled in some way, that women's fertility needs to be controlled. And it's a very interesting, very fascinating overview that's also full of a lot of contradictions. On one hand, the woman as an actor in reproduction was seen as being quite passive, as being like a seed bed, basically just carrying the child, which was already kind of fully formed in the father. But on the other hand, there was also the idea, sometimes perpetuated, that wombs had sort of a life of their own, that they, you know, kind of wandered the body and could affect overall health and temperament, and that menstruation too brought with it some kinds of strange symptoms and afflictions. So our overall conclusion here was that all of these speculations, kind of whether they were seeing the womb as a source of power or as a source of, you know, women's passivity and otherness, in every case it was seen as something quite mysterious and as something that made women other to men, and that the male body was seen as the default and kind of the perfection. Then women and their wombs were characterized in opposition to that. So then in the early 20th century and onward, with the development of certain technologies allowing us to see into the womb during pregnancy, to visualize the fetus, and even to interact with it in certain ways. This inaccessibility, direct inaccessibility of the womb disappears. But as we can see, there is kind of a legacy of these opinions about women's bodies, opinions about pregnancy and fetuses still remaining and kind of framing the development of these technologies as well. So as on one hand, I guess that is the big dilemma when it comes to reproductive technologies in general. On one hand, having more knowledge about the course of pregnancy, about the state of the fetus and so on, is something that is potentially a source of further control and empowerment for pregnant women. But then on the other hand, when these technologies are developed in systems that see women as other and as not autonomous as men, and that value them largely for their reproductive capacities, as is unfortunately the case in most countries, then it's very possible also that these technologies can be subtly abused to increase the monitoring of pregnant people, and to shift, instead of giving more autonomy to women and more knowledge to them, to shift towards centering the fetus and having more strict and disciplinary conceptions of how women should behave in pregnancy. So we can see how this technology, with its potential to show the fetus more visible, and also as something that can be interacted with, has also bolstered these perceptions of the fetus as a separate patient and as having somehow separate medical or perhaps even life-related interest from that of the pregnant woman. And this has led to the related notion of maternal-fetal conflict that we wish to address in the rest of this paper. So maternal-fetal conflict is a contested concept, and it's difficult to find a unitary definition that everyone would agree with. But in general, it's understood as something that happens when pregnant women, act in ways that are possibly detrimental to the fetus. So the typically used examples are, for example, those of consuming excessively alcohol, or using certain drugs, or smoking in pregnancy. And this kind of conflict framework or model of pregnancy has been seen both in bioethics and sometimes in the law as actually the starting point. And the pregnancy is kind of already seen as a site of potential conflict, and the fetus and the pregnant woman are seen as opposing sides that might find their interests clashing, and that we then have to think of ways to adjudicate these conflicts. So we've looked at this kind of starting point, and we wish to argue that this kind of conflict framing is both practically and theoretically unsustainable. And not only that, but that it can also be actively harmful, in that this perception encourages the undermining of women's autonomy and a view of pregnancy that disempowers them. So I'll stop here, and I'll now let Chloe go on and say something more about this, as well as future technologies and their impact on the perception of the womb.
Thank you. So as Dania said, the rest of the paper really is talking about why we need to reframe conflict, both in terms of why we believe it to be conceptually and empirically unfounded, but also the importance of moving away from this very pervasive sense of what the womb is and does, and how it might potentially present a threat to a fetus ahead of new developments in technology. Because if we don't do that, some of the benefits that are claimed for future technologies, we won't be able to realise. So here are just a few reasons why we think that the conflict framing is unfounded. We can't go through all of them, so we've just picked out a couple. So the first is that conflict assumes that there are two entities. So there is almost a sense, and it's quite pervasive in the language that's used, both in clinical journals and often in bioethics ones, about sort of a pregnant person almost as a fetal container, because the fetus is a completely separate entity. And a lot of the technology Dania talked about almost, bolstered that to a huge degree. So the fact that X-ray and ultrasound allowed us to see a fetus produced all this imagery of the fetus seen as completely separate and taking it entirely out of its location within a person. And that sort of allowed us to start imagining a fetus as separate, as opposed to being part of a pregnant person. So there's a lot of really convincing different metaphysical accounts of what a fetus is in relation to a pregnant person, potentially a part of them or as part of a dyad. So Mattingly and Kingma take opposing views on that, but they both serve to illustrate that a fetus definitively is not a separate entity. It very much is located within a pregnant person. And so seeing them as two entities that can be in conflict, it doesn't really make sense when you think of the fetus within what it is and where it is situated. But moreover, it's sort of the conflict notion assumes that there are clashing rights at stake, and we're not entirely convinced that that's possible. Firstly, when it's not settled matter in ethics and law that there is such a thing as fetal rights in the first place, or fetal interests that can conflict with a pregnant person. But also, insofar as it detaches a pregnant person from their state almost by implying that they're always going to have interests separate from their fetus, as opposed to the reality of lots of pregnant people actually really caring about their pregnancy and the outcome of their pregnancy once they've chosen to carry it to term. And so sort of assuming naturally at the start point that they're a threat didn't really make sense to us. Secondly, clinical outcomes, and we cited lots of empirical evidence for this, for the health of pregnant people and actually for fetuses, are worse where narratives of conflict dominate care models. The reason being that where women are constantly spoken to, pregnant people are spoken to, like they're a threat to their fetuses or to their pregnancy, that gives them incentives or makes them less likely to engage with clinical models and not to engage with prenatal care. And also just people are best placed to know what their body needs and wants in lots of circumstances, and they're perfectly capable of listening to and following clinical advice where that's relevant. But we can see lots of cases where pregnant people, have very strong opinions about what they feel that is necessary in order to sustain their pregnancy in a healthy way. And we think it's important that we listen to them, and outcomes are very much better when we do. And finally, significant social and political implications result from the conflict framing. So we're seeing the implications of this now, right, with these potential NICE guidelines that recommend starting to record the behaviours of pregnant people in very invasive ways in order to try and gain more control over what pregnant people do in order to protect the fetus. That results very much from this framing, and it's very much a concrete harm that we need to avoid and mitigate. Can we press the next slide? Thanks. So that leads us on to womb with a view. So this is looking at ectogestation and future technology. So as we've explained, there are already reasons within the context that we live in now to move away from this conflict framing. But we argue in the rest of the paper that there is technology coming that might exacerbate the notion of maternal fetal conflict if we don't try and actively move away from this now. So ectogestation, that's gestation ex utero in a device attempting to emulate a pregnancy, like emulate a placenta, has been heralded by lots of bioethicists as a potential source of liberation for people with the physiology to become pregnant. That's almost exclusively placed on people with that physiology, usually women. And so, lots of arguments have been made about the importance of technology allowing us to share those burdens so that it isn't exclusively women who have to perform gestational labour. However, what we argue in this paper, we fully welcome ectogestation for the possibilities that it can offer different people. For example, people whose pregnancies might be dangerous, or people who don't want to complete a full-term pregnancy but still want to reproduce. However, what we argue is that those benefits that are presented by lots of bioethicists often assume that contemporary frameworks almost don't exist. Like contemporary context seems to be completely absent from lots of these arguments, because we need to think about how technology is made available to whom and in what ways. And we argue that given the pervasiveness of maternal fetal conflict, it's incredibly unlikely that unless we move away from what is here because of historical and contemporary context, it's this framing that's going to dominate how this technology is available. And if that happens, it might not be as beneficial to people with the physiology to become pregnant as it might intuitively first appear. And we present Two general reasons for this. So this is just ways in which maternal-fetal conflict might mean that ectogestation doesn't always benefit a pregnant person. So the first is the idea of a narrative of alternative as a mechanism of control. So we see this all the time at the moment, this idea of the fact that NICU exists at a particular point, so we can, in a sense, rescue fetuses from 24 weeks means that we limit access to abortion from that point. And that's almost based on a logic of alternative, and that's quite harmful. And you do see in the literature in places people already talking about ectogestation inappropriately as an alternative to abortion and inappropriately as an alternative to pregnancy. And we explain in the paper why this technology isn't an alternative to either of those things. And I don't have the time to fully go through both of them. But the problem is, it just to highlight really that having ectogestation would allow particular notions of, we can control this gestation more outside of the womb. And so, we need people who are behaving in particular ways, for example, to opt for this technology. Or, for example, not allowing certain groups of people to opt for the technology because they're not deserving. So we just have some concerns about maternal-fetal conflict actually dominating who's forced to use the technology or not allowed to use it in different circumstances. And then following on from that is this idea of pathologized gestation. So pretty similarly, we just wanted to highlight here really that there's quite a lot of pathological language in the case for ectogestation. So people talk about pregnancy as illness or injury or something that incapacitates a person. And whilst we don't disagree that pregnancy is, hard and can often, sometimes be fatal, particularly to certain groups of people, we worry about the use of particular language, situating pregnancy as always dangerous and providing further justification for it as a source of danger and to justify intervention. So we would argue that we just need to be careful in framing the case for ectogestation as not equally framing pregnancy as always dangerous. So this is just the last concluding slide. I'll be quick, I promise. In this discussion, essentially our entire purpose in tracing everything and thinking about future technology is just to highlight a few things. So the first is that discussion needs to place the fetus, and this is a quote from Pachesky that's amazing. We need to place the fetus back into the uterus back into the woman's body, and her body back into its social space. We can't keep imagining the fetus as a separate entity that has interests distinct from a pregnant person. Technological and medical developments need to be imagined in context to think about who has access to technology, when and why, to make sure that when technology appears, it really benefits the people who might need it and instead doesn't cause those material harms we were concerned about. And finally, we need to focus on reconceptualizing discussions around the womb. The womb is not a conflict zone, and we need to make sure that we appreciate that before the realization of new womb technologies.
Yeah, and just quickly to thank everyone again for listening, and just to flag that this paper is still available online and open access in the Journal of Medical Ethics. So if you'd like to read more, you can find it there, and we welcome any questions. Thanks.
Well, thank you so much, both Chloe and Georgia, for that really, really insightful talk, and really interesting to hear how your research kind of developed over the time and really helped to kind of redefine, okay, what is the womb as not only a biological context, but also as a sociological context, and how this definition is evolving as technology is getting more advanced. And interesting conclusions at the end, thinking about this kind of womb outside of the uterus and womb, this kind of exterior rooms, and how that would challenge some ethical beliefs. I think it's time to hear some any questions from anyone in the audience. So we've got 5 or 10 minutes for that. So if anyone wants to put some in the chat function, or if anyone wishes to unmute themselves and to raise a question, you're very welcome to.
Hi, I'm happy to ask a question if that's okay. Thank you so much, Chloe and Dunja. That was absolutely fascinating to hear about. I'm particularly interested in this topic because I was born through surrogacy, and I'm really interested to hear how you think that surrogacy, and particularly the laws that surround surrogacy in terms of the rights of the child separately from those of the mother, kind of interact with the work you're going, where you're kind of exploring them as one entity, where in the case of surrogacy in particular, they operate very much as two entities. I'm just interested in your views on that.
Tanya, do you want to answer first? Because I know that you have a paper.
Well, I was just about to ask the same, but I can start. Thanks for the question, Georgina. That's actually really fascinating. I have to admit I hadn't thought of it in that way. And I guess Chloe will probably have more to say on the legal side, but as I've also been interested in surrogacy in another paper that I've been working on, I guess I see the kind of potential for seeing the womb as a conflict zone as something that could very much affect potentially negatively both surrogates and their relationship with the intending parents, and then also, I guess, in the long term, possibly also the experiences of the children born through surrogacy. I realize that this is a complex case because regulations about adoption have to be instated somehow, but I think what we really wanted to focus on in this paper was the context of the pregnancy itself and how we can't really separate the fetus from the gestating person. And I think that in the context of surrogacy, this kind of focus would actually only strengthen the surrogate's rights and preclude any potential for exploitation. I don't know if that's helpful at all to answer your question, but this is just kind of my initial thought, that we hadn't really discussed surrogacy a lot in this particular paper, I think. Chloe, do you want to add?
I'll just add to that to say, I can see Zaina Mahmood is here from Exeter. So this is something Zaina and I have been thinking about a bit together. And I don't necessarily think that for exactly the reasons Donya's just explained, that imagining a fetus as part of a pregnant person actually harms a surrogate's interests. I think it actually benefits them, both in allowing them to assert their rights whilst undertaking a pregnancy, but also once the fetus is born, I think it bolsters the case for, and I'm definitely straying into territory of co-authored work with Zaina here, but I think it bolsters the case for recognising the intended parents as the parents after birth, because we sort of assume that gestation is mothering almost, because there is this separate entity to be looked after during a pregnancy. And actually, I think it would help us quite a lot to think about, a surrogate as performing a gestation, and the fetus is like a part of that person. But then once it's born, it's genetically related parents who intend to parent it, for example, can do that, because that's when the entity comes into existence as a separate entity. I hope that's at least something else to think about.
Yeah, thank you.
That's a really great question. Thank you.
Sorry, Georgian, I think you were cut off. Was that helpful to answer your question?
Yeah, no, absolutely. It's really interesting. Thank you.
Lovely. Well, thank you for answering. Is anyone else who would like to? We've got time for one more question. If anyone would like to ask one now. Otherwise, to say thanks so much, Chloe and Ginger. It's really, really interesting to hear. And at the end, with time dependent, we might come back to kind of some more holistic questions, which might overlap between Sarah's work and your work. So without further ado, I'd like to welcome Sarah. So Sarah's going to be talking about her paper, and so looking specifically at the concept of gender identity and whether it should replace sex in the GMC medical records. So Sarah's from King's College London. So Sarah, the floor is yours.
Great, thank you so much, and what an interesting presentation. Let me just see if I can make this work. Is it working now? Okay, great. Oh, probably want to start from the top, don't I? So, hello everyone. I'm Sarah and I'm at King's, and today I'm going to be talking about the GMC advice about sex and gender identity in the clinical record. So we're going to go over some concepts because there's differences in terms of how people will define things. And then we're going to use Beecham and Childress's 4 principles approach to kind of analyze the ethics of the question. And I'm going to finish with a kind of tentative practical suggestion for perhaps one way forward. So what is it that we're specifically going to be looking at? It's the trans healthcare advice pages on the GMC website. And there's 2 points under confidentiality and equality that I'm going to be looking at. And the first is respect a patient's request to change the sex indicated on their medical records. You don't have to wait for a gender recognition certificate or an updated birth certificate. And the second point is don't disclose a patient's gender history unless it's directly relevant to the condition or its likely treatment. It's unlawful to disclose a patient's gender history without their consent. And so the way I've interpreted this advice is that it does 2 things. So the first thing is that it alters the meaning of the word sex in the medical record itself, because it means that the sex marker doesn't necessarily denote reproductive biology, but is more about a patient's sense of themselves, so their gender identity. And the second point is that it discourages doctors from talking about biological sex using kind of more traditional nomenclature, because that is what is implied by the term gender history in this context. So to begin with, we're going to just kind of go over some of the really basic concepts, because I think I use them slightly differently than they're used in other places. And the first is sex. And I understand this as a binary because it's dependent on 2 different types of gametes, 2 types of reproductive systems, therefore 2 sexes. And from my understanding of the language of medicine is that words like female and male are related to this kind of concept. And an individual is female or male based on genetic factors, anatomy, and physiology of the reproductive system. There are variations in sex development, and these affect kind of a minority of individuals. But this is going to be irrelevant for the analysis of the kind of GMC healthcare advice, because they are not applicable to the question at hand. In other words, so trans patients aren't actually kind of having any reproductive atypical features of their sex, but their issue is that they might be reproductively normal for their sex, but they identify as being other than their sex. So really the question to be explored is whether somebody who is clearly female or male can become, in effect, the opposite sex, or to say they have no sex at all, and whether they can do so by self-declaration. Now, medically induced physical changes can, of course, be achieved through things like cross-sex hormones and surgery to genitalia or removal of various reproductive organs. But in my view, the notion that these actually would change someone's biological sex seems false. Also, such an idea would mean that patients would have to be classified on kind of a spectrum of more or less female or male, depending on if they have a hormonal imbalance or need their organs removed for some other reason. And it would seem kind of unkind, for example, to tell boys with transient gynecomastia that they're now kind of more like girls. And it would also seem quite cruel in a sense to tell a woman after she's had a hysterectomy for cancer that she's now more male. And really, the question is the kind of words that we're using for these 2 different types of systems. Of course, there are individuals, so trans people, who might take hormones to induce kind of breast growth or have a hysterectomy as part of gender affirmation. And perhaps it is to some degree the intent behind those interventions or the person's psychological identity that's an influential factor in how we think of them socially or how we might label them within medicine. But it seems somewhat biologically, and from my understanding of medicine, incoherent to say that some individuals would biologically change sex, whereas others don't, if the very same kind of biological parameters are being altered. So there's a question of consistency there. And so my position is that until medical science allows for, let's say, a reproductively normal female to completely transition to fulfill the reproductive role of a male and vice versa, then in my view, sex would remain fixed. And further, I think medicine really does need kind of specific words for the two biological sexes in humans that mean specifically those kinds of structures and biological concepts. Because, for example, the concept of an organ system is inadequately conveyed through referencing only one of its kind of constituent parts or functions. A very recent example of this was The Lancet recently had on its cover bodies with vaginas, which was roundly criticized as dehumanizing. And phrases like epididymis haver would only carry specific meaning as to the presence or absence of an epididymis, whereas male would indicate the kind of more of the whole reproductive type of system. And so it's my contention that even if medicine would wish to rid itself of a scientific meaning of kind of female or male, like to unanchor these words, let's say, it's likely that science would still just need to kind of come up with new phrases or workarounds to kind of indicate the same thing. And so we move on now to gender identity. And so this is the Genderbread Person, a learning tool developed to illustrate different concepts of gender and sex. And the point of this is just to note that these two ideas are being kind of separated out in this particular kind of diagram. So gender identity in and of itself is somewhat difficult to define, but I would go with Stonewall UK's definition, which is that it means a person's innate sense of their own gender, whether male, female, or something else, which may or may not correspond to the sex assigned at birth. And so it's kind of this really highly personal and subjective phenomenon, which is indicating maybe a state of mind or a sense of self, but it's unrelated in any sort of physical sense to reproductive biology. And so trans people are those individuals whose sense of themselves or how they wish to present in society is incongruent with cultural stereotypes or physical features associated with their sex. And the point here is that some trans patients may be diagnosed with a medical condition such as gender dysphoria, or now it's gender incongruence, but they may or may not actually experience any kind of significant discomfort or distress about their sex body. Or they may or may not have various interventions in terms of hormones or surgery. And all of these are kind of equally valid, of course. And so the point really for medicine is that trans is an umbrella term, which is very, very broad and contains such a heterogeneous group of people. And concepts in this area are being regularly refined and redefined. And so language is evolving quite rapidly. And so that's the question then that meets this issue of medical records. And really the question of whether or not someone should change the sex on their medical record is tied into what that actually means in a practical medical sense. So of course, trans patients are a minority group who face various different barriers, which have been well documented in forms of discrimination. And they have these very unique health needs, but also they share health needs with other patients, right? So just because someone's trans doesn't mean that they somehow no longer need, let's say, routine hypertension care or that kind of thing. And so the argument that I wish to make is not that anyone's identity should be disrespected or that confidentiality should be broken. And this isn't about the law, but it's more just that because there are two separate concepts at play here, so sex and gender identity, the potential for tension within them in a healthcare setting it exists, and I think is quite significant. And so I think the case of Cameron Whitley anecdotally reveals this quite well. So Cameron was born female, but was registered as male in the medical record. And the doctors consequently used the wrong reference range for Whitley's biology and failed to correctly interpret how severe the illness was and the degree of renal dysfunction that he had, which delayed the kidney transplant by over a year. And so Cameron, reflecting on this, says it was really cute and awesome that I was treated male, but in being this way, they, meaning the doctors, didn't necessarily take into account the body. And we move on then to the issue of respect for autonomy, because I think it's tied in quite strongly, of course, with the kind of a person's sense of self, etc. And we'll begin by looking at Wynne Wyatt's story, where he says, "It was the pill. I was stood at the counter for an hour and a half because they were very confused as to why they were giving me this medication. Because obviously my biological gender marker or whatever was not marked on my prescription, and my name was Winston Wyatt. And they were like, this is not for you." And I was like, it is for me, actually. And so clearly patient records should be holding accurate details about them and be amended in case of any error. And this holds true for gender identity and how someone's name and how they are interacting with the world. It would be wrong to prevent a trans patient like Wynne Wyatt from having a clinical record that correctly denotes their actual personal information. So of course, gender identity should be recorded. The question is just, what are the implications for autonomy if you are recording that in the place of sex in the record if they're two separate concepts? And so the question of language and how patients and doctors are communicating with each other, or how healthcare and patients are communicating with each other, becomes really important, because in order to ensure a patient is actually knowledgeable enough to make a sufficiently autonomous choice on this matter, the clinician might actually need to confirm that the patient understands what they mean by a biological definition of sex, the consequences of changing sex on the medical record, and the limits of medical intervention in the ability of actually being able to change underlying reproductive biology. And so rather than this being an administrative matter, which would be more like, changing an address or something, changing a sex marker to become technically biologically inaccurate seems likely to require a little bit more in-depth thought, perhaps assessment of competence and dialogue. Now, there are some who might even argue that a belief that someone is not of their sex could be demonstrably false. And if so, would doctors have some sort of moral obligation to explain to the patient that their identity is mistaken? And I don't think that would be the case at all. And I would say a firm no to that, because if the issue is gender identity, not sex, then that's not an objectively verifiable thing. Like, there's no way of proving or disproving someone's gender identity because it's highly personal. And the other point about gender identity is that it's clearly materially relevant to someone's life. It's very important, and so is perhaps even analogous to something like a really strong spiritual or religious conviction. And so if a patient believes that their identity is other than their reproductive biology, and they're competent, able to reason normally, and have full knowledge of any medical consequences of their belief, then the doctor has very little place, in fact, no place, in trying to tell a patient otherwise. So a medic arguing that a trans patient's gender identity is false would be in as wrong a position, in my view, as attempting to convince a devout Jehovah's Witness that they have to consent to a blood transfusion. And we move on then to non-maleficence. So this is Angela's story. I called the GP surgery to make an appointment. The receptionist asked me to repeat my name twice. She said Angela twice. The receptionist sort of sniggered and turned to the other receptionist and said quietly, but loud enough for me to hear, "He says he's Angela. What do I do?" I did get my appointment, but my stomach was churning. I felt terrible. That feeling comes back every time I need to make an appointment. So medics may clearly cause a trans patient significant distress by reminding them of their biological sex or disrespecting their identity. And worse still would be to display overly negative attitudes, like in Angela's story. And of course, apart from that, there are practically a lot of negative consequences and risks that could be occurring from just changing the sex marker itself. So there are problems such as identifying the correct reference images of blood tests, like we already saw,
knowing about pregnancy risk or interpreting urinary symptoms, for example. And the other issue is that trans patients, if you change the marker, will need to navigate a healthcare system without various aids that other patients might have, such as reminders for screening. And so a trans man would have to would have to book in manually for cervical screening if he changes his sex marker from female to male. And the question becomes whether or not the intended good of the GMC advice outweighs the bad. Well, this is a questionable one because the act of implying to a patient that a sex change is possible, even if it's just symbolic on a medical record, is a bit dubious, predominantly from a veracity or truth-telling standpoint. Because if it's not actually possible to change sex, then one could argue that even kind of doing so on a medical record may be a form of kind of medical deception. And if clinicians intend only the good effect, and even if some patients feel that there are benefits that outweigh any consequences, there is an argument to say that doctors shouldn't be promoting any untruths. So for example, a patient with COVID-19, you wouldn't record them as being negative for the virus if they were positive for the virus, regardless of how the patient feels about it. And so we move on then to beneficence, and this is Annabelle's story. I was like, I don't actually know what are the implications for managing my health provision moving forwards. For example, it would be important to know that she was not expected to be pregnant. The upshot was a phone call that lasted around 2 hours. I was trying to ask them the medical implications were of changing my gender marker on my notes, and they were trying to do the politically correct thing of saying, well, it's what you want, it's not about what we want. And in the end, Annabelle had her gender marker updated. A week later, she received a letter inviting her to cervical screening despite not having such anatomy. And so in the case of specific beneficence, despite the fact that trans people are very diverse, we can consider trans patients a group with particular health needs. And clearly beneficence would involve promoting the ability for them to live with liberty and having their identity acknowledged. And it's possible that this changing of sex marker might benefit some patients, but then examples like in Annabelle's story of confusion and later misunderstandings are notable. And one thing to consider is the point of recording sex in the clinical record, which is that it's intended to help the doctor fulfill their role of promoting a patient's well-being. And the question is whether or not it's an act of beneficence, in that case, to obscure sex biology for trans patients. In the event that there is a mismatch between sex and gender identity and it's apparent to the practitioner, healthcare professionals are likely to become confused and seek clarification about the patient's reproductive system. But this then could be extra burdensome on the trans patient themselves, who has to then re-explain the situation, which could be distressing. Furthermore, attempting to obscure a patient's sex could be impractical. So for example, if someone's ordering a prostate-specific antigen test on bloods labeled female, it's likely that the laboratory would still call up or even cancel the test itself because they notice that there is an incongruence. And then you have either the choice of explaining that, yes, this is exactly the patient that I wanted to do the test on, in which case you've revealed the fact that that patient is trans, or you end up not changing the sex marker, in which case you would probably have less of a discussion, like you would have probably stopped that situation from happening in the first place. And beneficence also means questions like thinking about the future needs for trans patients as a group, like research, and whether or not changing the sex marker for a trans patient would end up hiding them and obscuring their data into the data of the opposite sex instead of being able to identify them as a discrete group who will need things like tracking of long-term health outcomes or effective medical interventions, and being mindful of issues like minority stress. And so we move on then to justice. It essentially makes a really life-saving kind of care dependent on your ability to be resilient and to be prepared to go through something that I think a lot of patients don't ever have to go through, in terms of being vulnerable and being willing to have basic dignity and selfhood challenged. And a lot of people can't do it. A lot of people just can't do it. They don't go to the doctors anymore. They stop going on care. They self-medicate, or they self-harm, or they experience suicidal ideation. And that's often where we as advocates actually have to step in. And unfortunately, not enough people know that advocacy is an option. And I think that's quite a heartbreaking story from Jack Doyle. And clearly, trans patients should be given the ability to flourish. And central to this is providing a welcoming environment for them, specific accommodations, and opportunity to engage with healthcare provision. But as outlined already, changing sex marker may add to more difficulties experienced by trans patients rather than make things easier. The other point on justice is that there doesn't actually seem to be an equivalent right for all other patients in other areas of healthcare to determine what's written down or communicated in their medical records when it comes to various facts. And so one question is whether it's fair to extend these sorts of privileges or these sorts of rights to only one specific group. For example, patients with severe recurrent depression might not want to have their mental health issues on the medical record, but it would still be useful to have those things recorded, and they can't necessarily ask to just have them removed. And this is the same for smaller issues like age or weight, or maybe a blood test someone doesn't like. And the other question is, if you then start altering the facts in the medical record, this could impact on doctors' ability to do their work. So if they can't trust that what's written down is an accurate reflection of someone's medical history, what does that mean going forward in terms of what they can trust of what's being written down? And the other question about justice is that there are various individuals under the trans umbrella, and non-binary gender identities, for example, can't be adequately documented under sex using the male-female system. It seems problematic for trans healthcare that this sorts of advice from the GMC might incur that some patients are treated more favorably than others just because of nuances in let's say, their gender identity. But more importantly, from a healthcare system's perspective, the advice also raises serious concerns about patient safety, which is important when you think about the fact that the GMC's role is partially to protect patients and the public. If the GMC implies that sex markers should not always reflect biology, and doctors should not be encouraged to ask about mismatches, one question is whether or not this could lead to a removal of a layer of safeguarding, because it could become more difficult to rectify and identify genuine labeling requests or prescription mistakes. Healthcare systems are very complex, involve lots of different layers of communication, and it may not be the soundest advice to imply to healthcare professionals that they should be ignoring any kind of incongruence and not seeking clarification if they notice information that doesn't fit their expected pattern. The other point on this is that the GMC advice involves resource implications, because there could be some trans patients inappropriately considered for tests, as we saw before, or need to have the same test performed more than once because it was rejected due to a mismatch between biological sex and their identity marker. The other point is that on information handling, also, if you're creating an entirely new record, this could place extra burdens again on trans patients themselves, because they are then the only carriers of that information if there is no link between their previous identity and the medical details there and the current one. And in a time and resource short healthcare settings, one of the questions is what these extra tasks needed to compensate for these policies might mean in terms of efficiency and just distributions of clinical efforts. And so in summation, the advice issued by the GMC that a patient should be allowed to change the marker for biological sex in their medical records implies that a clear word for their type of reproductive system should be ignored or at least hidden in their confidential medical history. I personally find it quite perplexing and potentially quite disruptive, specifically to patients and trans patients themselves, but also to doctors who aim to deliver kind of excellent quality care. The other point that was worrying about doing the research on this is that in correspondence with the GMC, it appeared that this particular page had not been through any kind of formal development process, because it's not specific guidance, it's something called advice. And it's unclear what doctors should be doing if they're worried about possible negative consequences associated with changing the sex marker for a trans patient. And because it constitutes advice rather than guidance, this also means that practitioners might interpret these guidelines or advice flexibly, and this could mean differences in practice for trans patients. So thinking about a solution, it would seem simplest if there was a system whereby you could just record both. So you could have sex just be female or male and just have that be biology. And then you can have gender identity as a free text box, which could then encompass whatever nuance of, gender identity that someone has. You could put in gender queer or gender fluid, and you could detail that kind of information. Or if there's, not atypical, but pronoun use, which isn't the standard he or she or they, you could enter that there too. But the main point really seems to be that the biggest challenge for doctors moving forward is to try and understand these concepts and to get to a level where they don't make a big deal about the fact that a patient is trans. So ideally, I would quite like to see a future whereby healthcare professionals could quickly look at patients' confidential medical record, see sex and gender identity, understand what those things mean, and if there's an incongruence, think it largely as, as interesting as the fact that maybe a patient has, I don't know, diabetes or something like that. So basically, okay, good to know, but not anything that they would necessarily get caught up on. And I think that sort of system would be far preferable to the current GMC advice, because that would enable someone to go forward with better comprehension of a trans patient's medical needs, as well as respect their dignity. And that's it. Thank you.
Well, thank you very much, Sarah. It was a very interesting talk and very interesting to kind of hear out the complexities of it's not just a biological concept, there's very much of the sociological impact, and we all have a duty to play to ensure we all ensure that all our patients feel valued and have a voice in the healthcare setting. We've got time for one or two questions if anyone does in the audience. Again, either in the chat function or if someone wishes to unmute themselves, please go ahead.
Hi, can I ask a question?
By all means.
Hi, thanks, Sarah, for that. That was really interesting. So I have two questions, if that's allowed. Sorry. So the first is just, I was really interested in the fact that you set up sex as a binary, but also a binary that's specifically divided by reproductive function, when that's a very small subset of a human entity's entire physiology. And I just kind of wondered about why thinking about sex as a binary is like actually quite problematic for large sets of people. So for example, that includes people born intersex, for example. They don't easily fit into male and female categories, and being forced into those categories is really harmful. But also people who sit at the boundaries of those categories are spoken about and treated in really awful ways because they don't quite meet expectations of those categories. So I was just wondering about the defense of sex as a binary in a bit more detail. And then the second question is, I guess jumping off there, the argument sort of assumes that we understand physiologies really neatly and how different medical treatments relate to physiologies in quite neat ways. But actually something I've been thinking about at the moment is that like medical models are almost built off the very typically male physiology all the time. So like, does necessarily not recording somebody as potentially having been born with female physiology not always impact on the care that they receive being suboptimal anyway? Like, I mean, I appreciate that it might do on things like cervical screening, for example, but like we already aren't as good at recognizing the symptoms of a heart attack in someone with female physiology, for example. That was just some thoughts. But thank you so much.
No, thank you. Very interesting questions. And so I think on the first point, in terms of the defense of sex as a binary, I think for me, it all comes down to so I understand the point that, oh, how do we classify people as female or male can be a bit complicated. And I think that's specifically the case for people with variations in sex development, and particularly those who would have, as I think Leonard Sachs would say, classically intersex, in terms of someone's phenotype and their genotype being expressed in such a way that it would be somewhat difficult to say this person is female or male without a little bit more explanatory detail in terms of this, but they have this and this particular condition, so to speak. But the reason for setting up sex as a binary is because there isn't really a name or a there's no name for any of the other sexes. And if you unanchor sex from reproduction, then it kind of then the whole kind of concept dissolves, right? Because the whole point of us having two sexes, the whole point of us having sex is because that's how humans reproduce as a species. And that's dependent on two different sets of gametes. And that's why it's a binary. So if that makes sense. So it's not necessarily about how do we classify an individual person. It's about what is the broader concept that has led to the fact that there are two different sorts of individuals, if that makes sense. And so that's why I would classify it as a binary, because that's how human reproduction works. And it's not about whether or not someone is able to then reproduce, if that makes sense, because it's not, someone could be infertile and they would still be female or male. And then now I seem to have forgotten the second question. What was the second question?
I was just asking about whether, obviously, outside of specific examples, we don't understand physiologies neatly because we base everything on a male.
Oh, the male is default. Yes, I remember now. Okay, yeah. So that's a good question also. So the point about that is that actually by if you don't understand female and male as separate in and of themselves, if that makes sense, if you're not recording female and male accurately. So part of the problem with that is also that there's not enough sex disaggregated data. So there isn't enough kind of pointing out, okay, well, we're doing this in, female models, let's say, if you're doing animal research or something like that. Or we're going to be doing this clinical trial, but we're not actually looking at how it might impact females or males differentially. And so really the question of having the sex marker be a biologically determined category would hopefully then help with being able to pick up things in terms of differences in female and male physiology, if that makes sense. Because unless you're able to identify them as discrete categories, the problem is just going to be getting worse. And for me, it seems to be it's not really good enough for me, at least, to say that, oh, well, let's say someone is born female and then identifies as a man and is down as male in the medical record. It doesn't really it seems suboptimal to say that, oh, well, they were already, this individual was already being treated more poorly in terms of medical understanding of their body and their health needs as a female. And therefore, what does it matter if we then also aren't really able to find out what's happening to them, because now we're hiding them in the male category. You know what I mean? I don't see how that is helpful either for that specific person or in a broader sense in terms of figuring out for that individual, but also for other individuals who are female and then identify as men or non-binary.
Chloe, as your question,
I'm conscious that I'm talking a lot then. If anyone else has a question, maybe you can ask it first and then I can ask more if there's.
okay. So, I didn't want to interrupt you, that if you had a follow-up, that's all. But the floor is always open if people wish to put a message in the chat. I'm very conscious as well that we are over time. But this is the beauty about medical ethics, is that we could have endless conversations on these topics and more topics. So very much if someone else wishes to raise a question, please do. But otherwise, I'll let Chloe kind of, if she has any follow-up, I'll let her have one more question, and then we'll close it there.
I guess, sorry to jump in. I kind of wanted to ask Chloe and Dunja about their take on their paper. So obviously the women's autonomy and the way that women are presented in a lot of medical and historical things I completely agree with, and it is being set up as there's a lot of conflict between the way that women are presented in medical historical texts. But I guess my question is going forward, if we put all the emphasis on sort of the maternal autonomy for pregnancies where the woman is saying that she's going to continue the pregnancy and not have an abortion, does there not become a slight, I don't know, sort of responsibility to the fetus that she's carrying to provide the best kind of care to that fetus? So we would see a lot of women who we know that smoking is really bad for the baby, but they'll continue to smoke, or they'll have several children that have growth restriction because of smoking. Now, that doesn't mean that they're going to be a bad mother to that baby, but where do we sit in terms of kind of putting all the emphasis on the maternal rights, and is there maybe scope to preserve the fetal rights in there at all?
Donya, do you want to go first or shall I?
I don't mind if you start. No, thanks for the question. Yeah.
Yeah, thank you. I guess so two things. The first thing is, I'd say a lot of the times when we say we know X or Y is bad for the fetus, there isn't actually the data to support those kinds of conclusions. So for example, at the moment, people are talking about why you shouldn't have a glass of wine when you're pregnant, when actually all of the data only talks about those kinds of extreme cases of growth abnormality or whatever in situations where people are grossly abusing alcohol, and then that's diffused down into these obligations. People have to vastly change their lifestyles in a multitude of ways. You can't, it's very difficult to go into a pub as a pregnant person, even if you're not ordering alcohol. It's incredibly difficult to do all sorts of things, even where the data doesn't actually suggest it could be that harmful to a fetus. So I guess my concern is that if we start asking we're already asking all of those questions from the perspective of how we can protect a fetus, and the argument for reframing it is, I think is really necessary precisely because we're already thinking about it in that way. So the shift to me isn't a problem, and I think we can trust pregnant people, and we should be trusting pregnant people to make the decisions they feel are best for them. And in the circumstances where potentially they may be doing something that could cause fetal harm, it's better for them to be engaged in prenatal care than not, for them to be physically healthy and for them to have the best outcome for their pregnancy if that's what they want. So for me, I kind of feel like the outcomes for pregnant people and for fetuses are better if we respect maternal autonomy or pregnant person's autonomy. I don't know whether you have anything to add, Donya.
Well, I mean, yeah, I guess I was going to say something along similar lines. So thank you. This is one of those things that when you're writing a paper with several people, you can often find differences of opinion. And I remember that we were discussing whether truly any possibility of maternal fetal conflict is really impossible, and whether we can't speak, because you can imagine a situation where it might seem quite clear that the pregnant person is in some way, for example, harming the fetus. But I think, as Chloe said, when we look at this kind of dominant model, and when we kind of think about this default, then I think the point is that we don't want to instill this as a kind of ethical and legal model, because that then kind of creates a mistrust in women. And as Chloe said, like having access to proper prenatal care rather than dissuading women from engaging in it at all is most likely to be what's best for their well-being and that of the future children. And also, just on the topic of smoking, sorry, since that's the example that you raised, actually, there's a really great paper that we've cited extensively in our paper by an author called Catherine Bowden, who writes especially about these programs of trying to prevent or encourage smoking cessation in pregnancy, and to test for carbon monoxide. This was a proposed intervention, I think, in some parts of the UK. And she writes very well about how this kind of conflict model then instills, mistrust of women's intentions, but also how the outcomes of smoking, and I think similar stuff has been found empirically also with other, usually taken risk factors such as alcohol, is that, for example, nutrition quality and other factors that are directly related to income, for example, are usually more determinative actually of fetal outcomes than. So a lot of this has to do with the kind of very cross-cutting issues of class and social position, and again, of who might end up being marginalized. So this is another reason why we want to be very careful, want to tread very carefully when it comes to speaking of any kind of fetal rights. Sorry if that's a bit of a long-winded answer, but
No,
do look at Kat's paper. It's a really interesting one.
So it would be more that you would want to keep the maternal autonomy and focus on the mum's healthcare, but not necessarily give the fetus rights of its own.
Yeah, because as Chloe said, there's actually quite a bit of a focus on the fetus, and it's becoming even stronger with, when you look at kind of news outlets reporting on pop cultural kind of popular science studies of, what might harm babies in pregnancy and such. You can see that there is already a kind of presupposition that the fetus is something that needs to be protected. And we're not trying to argue that there's no, rather it's a totally different debate whether there's any plausible conception of maternal duties or parental duties to the unborn. We're just trying to shy away from establishing the fetus as like an ethical or legal entity in its own right, because we feel that this can lead to many kinds of negative consequences.
Thank you. It's very good answer. Jennifer, do you want to follow up, or are you happy with where that's going?
No, that's fine. Thanks.
Yeah.
Thank you.
I'll ask Sarah another question if that's allowed.
Yeah, no, of course.
I know we're really over time. I was just again, this might just be my brain and the way it's working, but I still am really struggling with the idea of like a broader conception of how human reproduction works, defining who entities are and as individuals and how their bodies work and how we respond to them and treat them, and like in terms of social institutions like medicine are. And I guess my feeling is more just like the question about the male model thing was more to do with, if we already don't know so much stuff based on people's physiologies, should we not be taking an approach of like, we know that this level of this hormone would impact the way this drug works, so based on what we know about your body, whether you identify as male or female, just because obviously like quite a lot of trans people do. I don't want to speak because like too authoritatively about it because I don't have the lived experience, and I think in debates like this it's really important that we centre the lived experience, but people do describe themselves as male or female and feel very strongly about the fact that they are male or female, even if they were, by your definition, biologically not. So should we not just be focusing on reworking models to respond more closely to differences in physiology as opposed to categories? Does that make sense?
Sort of, but I think it's kind of something along the lines of, is there another metric that we could be using instead of this kind of sex as female or male in terms of a binary? is kind of how I'm thinking. Like, so your question is a little bit along the lines of, oh, so testosterone might do X, Y, and Z, or estrogen might do X, Y, and Z. And so could we perhaps tailor something closer to a person's like individual situation or something along those lines? Is that about right? Ish, don't know. But so anyway, the question of the reason for, I'm going to start from the top. So the reason for anchoring this in terms of sex in reproduction is because that's the kind of, to me, that is the reason why we have it from a biological sense, in the same way as, you know, if you look at an alveolus or something within the lungs, the reason that we have that alveolus is because we require oxygen in order to live, right? So it's kind of like the bigger scientific concept that is then giving rise to what we are viewing on a biological sense. And because there's only two different kinds of gametes, that means that there's only two different kinds of sex as far as I see it. And then within the categories of sex, you can have variation. And so the reason for kind of highlighting that is that even in the example that you give, for example, of, you know, an individual who is perhaps, let's say, male, but identifies as female, how, for example, their baseline physiology will still affect how the whatever intervention it is that you're giving them will affect them, right? So if someone is technically male, is biologically male, and they're given estrogens, their bodies will still respond slightly differently than someone who is female and is also given estrogen. And the point is that we don't necessarily know all of those things very well, because that's something that we haven't necessarily looked at in close detail over a long time. And this is compounded by the fact that so much of medical research and so much of what we know about medicine is already centered on the male medical model. So what we know about physiology and anatomy, etc., is very male-centered from a kind of historical perspective. And there's still quite a lot being done in terms of trying to redress that. Right, so that's in sex and gender medicine. This is particularly important. But the point is, we won't be able to collect that data and be able to elucidate it without having a baseline understanding of this is the population that we're looking at compared to this population, and to have some sort of set, even if the boundaries can at some point be fuzzy, you need to be able to say, these are the male people, these are the female people, and these are the differences between them, in order to be able to understand what the complexities are of that picture. And so if we take, for example, let's say if you wanted to use something like hormone levels, that's not going to tell you enough in and of itself. So if we take the male who's on estrogen, for example, what happens is they might have a change in the parameters, for example, of their hemoglobin levels, because that's what happens when you are on estrogen, is your hemoglobin might drop down to more female typical reference ranges. But what we don't necessarily know is that what that then means for that individual going on long term, because it could be that because of the size of their body or because of how their body is from that baseline, that then could lead to someone to have, for example, a functionally chronic anemia. And would that then have implications on their health when they're older? And so really the point that I'm trying to argue is that we still have a need for the kind of sex concept, so the kind of baseline at which people are starting, which are more clearly defined than anything that I've been able to see in terms of any alternative that's being given, right? So it does me no good if I am told that someone has a you know, an estrogen level of whatever it is, unless I also know this is what their baseline was, this is how they were, this is why they're taking it, and this is the kind of duration of period of time, because it's a very different situation clinically for, let's say, a person who is born female who's taking estrogen as a contraceptive versus a person who's born male who's taking estrogen as part of gender affirmation. on a sort of biological sense. Does that make sense? So it's really, the point that I'm trying to make is that the sex is still required for that contextualization and for understanding, particularly in the sex differences between females and males. We still don't know, there's still so much that we don't know because females have been under researched, that the more data points that we are able to gather and the more clearly one is able to say, right, this is, you know, this is this person's kind of baseline biology, then the more helpful it will be in the future for everyone, really, not just trans patients.
Thanks. I will go read your paper. I think you referenced it at the end, right?
Yeah.
Great.
And I think that offers a good leeway just to say, you know, for everyone here or everyone watching this online after this day, please go and read these two amazing papers that we've heard about for the past, well, just over an hour and a, nearly an hour and a half. And these conversations are hugely insightful, you know, to give us all understanding beyond the paper and really understand kind of the crux of really what we're trying to talk about here. So to Chloe, to Dunja, and to Sarah, thank you. Thank you very much on behalf of the Institute of Medical Ethics. Thank you on behalf of Phil and I today for coming along, presenting your papers. It's been fascinating and it's been really insightful. I'm certainly going to be reading both your papers in a different line now to understand a bit more about how me as a healthcare professional, but we can work as to make change. The final thing I'll say is that this is not the end of the IME's virtual seminars, and we have the next one on the 20th of October, and it's at 2:30 p.m. that time, and we're going to be hearing from two other authors. So the first one is going to be on public inquiries, help and maintain or even restore trust in the NHS, with the second speaker being looking into a qualitative study to understand are we all translators and how we can help patients who maybe their first and native language is not English. So that'll be on the 20th of October on a Wednesday evening. So we very much encourage for everyone here who came along to engage in our future events like this. And if this has inspired you, if you've got research which you would like to put forward, please get in contact with us at the IME. And we always love to hear about you and work with you to see potential avenues we can explore to promote your research. That's all for today. Thank you all so much for listening. Thank you, the presenters, for sharing your really, really interesting talks. And I hope to see you all soon in another virtual event. Thank you.